Let us now talk of how to investigate a case of liver disease. So to assess the general condition of patient, our common grid is hemoglobin, TLC, DLC, ESR, GBP, blood urea, blood sugar, urine stool. And then to assess whether there is jaundice. So the first thing you can do is serum bilirubin. Then you can do a Vandenberg reaction, which is indirect positive in case indirect bilirubin is raised, which is direct positive in case of direct or conjugated bilirubin is raised, and which is biphasic when there is a cholestatic jaundice because of intrahepatic inflammation. And then both direct and indirect bilirubin are raised. The second important feature of obstructive jaundice is that alkaline phosphatase is raised and urinary urobilinogen is absent. Thirdly, we can do an X-ray and find out whether the liver is enlarged. On X-ray, the liver shadow is enlarged, or sometimes the amoebic liver abscess may burst into the lung and you may get a simultaneous pleural effusion. Also, you can comment on the cardiac size or cardiac shape to suggest any reason of congestive cardiac failure. Then you can do portal wedge pressure and through the spleen, which may be enlarged, and judge portal hypertension. With that, if there is a case of liver cell failure, you can do prothrombin time, prothrombin concentration to early detect coagulopathy, and BT-CT you have already done, bleeding time and coagulation time. And you can also do a blood urea and serum creatinine. But in liver, urea is not formed and the encephalopathy is ammonical. Whereas in renal coma, the encephalopathy and all problems are because of raised urea. Then you can do a liver scan or ultrasound of the liver or MRI to detect any structural change in the liver. Then how would you manage these cases? So the management is that first of all you will manage the cause. You treat the cause. And the second thing is that you will look after cholestasis, intrahepatic cholestasis during the viral inflammation. And in treating the cause, newer drugs have come to control the viral load, and there are newer methods of investigation by which you can determine the antibody response against the virus and the viral load itself, and that has to be closely monitored in people who test positive, and you have to deal with that also. That is the newer part of management. Then if there is extrahepatic obstruction, you have to deal with the extrahepatic obstruction. You may have to remove the gallbladder, you may have to remove the stone, you may have to widen the sphincter of OD, doing what is called as the ERCP, or you may have to bypass the obstruction. In case of carcinoma of pancreas, you may have to do a cholecystogeganostomy, or you may simply have to drain the gallbladder and drain the bile outside. So those are the various modalities of management, and the prognosis of course depends on the cause. Amongst the conditions that can acutely kill are viral hepatitis, especially hepatitis type B, by the hepatitis B virus. Something that can cause chronic problem and chronic disability is hepatitis C or hepatitis D and E. Something which is more curable but is still acute is hepatitis A. Amoebic liver abscess is a toxic condition but responds well to drugs. Portal hypertension can basically lead to hematemesis, which can be dealt with by endoscopic coagulation of the blood vessels or by what is called as the Tanner's operation or by a splenectomy or by fusing the portal vein with the renal vein, the portorenal shunt, and liver cell failure may need liver transplant. So these are the conditions that have to be dealt with by. This is how you basically deal with liver disease, and the prognosis varies from point to point, but usually the prognosis is very bad, and therefore the most important part of prevention is that stay away from alcohol. That's it.